Okay, so today we're talking about acid-base imbalance. Now you should have your acid-base imbalance packet out. It looks just like this. It has a lot of what's on the board inside of it already. Don't go scrambling trying to write everything. And I'm going to be working out of mine, but I want to show you something really quickly. Whenever we're talking about acid-base, of course we're talking about the pH of the bodily fluids. And all bodily fluids have either an acid or an alkaline type of pH. Even blood, although all of us go, blood is 7.35, 7.45. Well, if you remember back in chemistry, the number 7 was neutral. So 7.35 to 7.45 means that blood is actually, I'll point to it up here, blood is more alkaline. Now, hopefully when I'm doing this lecture, wherever I point, it'll be easy to see where I point to. So if you look up here, it's kind of hard, but it's at the very bottom of the chart, and it has all the bodily fluids. And like I said, blood is on the alkalosis side, okay? Now, so we have bodily fluids, and if you look at my chart, you can see that there are colors down here, and you actually are responsible for knowing the colors. The acidic side is going to be yellowish orange, red even, and then of course the alkaline side is going to be on the blue or purplish colors. So if you consider the typical bodily fluid that nurses actually know about without thinking it too hard, there's two of them that we kind of know that makes sense. There's the stomach, and that's hydrochloric acid, so of course it's under acidosis. And also urine. Urine is acidic. Everybody kind of knows that. Okay, so those are some things just to remember. Then, like I said, on the alkaline side, a good one to know is that saliva is alkaline and that blood is on the alkaline side. You may, for maternity purposes on your NCLEX exam, you may even have something about amniotic fluid. Certainly you had to know that amniotic fluid was also alkaline because we actually use what we call litmus paper or a pH strip to test it, and it turns blue. Blue is alkaline. That tells us that the woman's water has broken, and not, get this, that the baby has tapped her in the bladder. So if you figure that urine is acidic and amniotic fluid is alkalinic, then of course amniotic fluid should turn blue. If the water is not broken, then you'll get an acidic urine type of issue, which is more yellowish orange. And so this is why it's so important to understand acid-base imbalance. Now, so as we get started and you open up your packet, what you'll end up seeing is my chart. This packet actually is going to include two different things. It's going to include acid-base imbalance as well as electrolytes. Not just the acid base, but also your electrolytes. So if you're having a test at your school just on acid base and maybe respiratory or something combined like that, save the electrolyte issues for later and just focus on the actual acid base. Now, so for the purposes of this lecture, if you open up your acid base packet, you will actually see the chart, which we're going to go over right now. And it talks about acidosis versus alkalosis. You will see Rome, which is up here. You will also see the most important handouts for this lecture, including the causes and signs and symptoms of alkalosis and acidosis. And you will see some worksheet papers in here. Literally, you'll see some worksheets based on your pH calculations and how we figure out if a patient is partially compensated and all the things that you guys hate. So let's do the easy part first, because I know you don't like math and neither do I. In fact, I failed math, so there. And I'm your teacher, so that's weird. So here we go. If we look at the chart that you already have in your packet, this chart basically is helping you understand how to rationalize why things are acidotic or alkalotic. And so when we look at acidosis, we have a couple of tricks up our sleeve. The first trick is to focus on what I think everybody really understands, and that is this word right here. Because if you focus on this word right here, which is hypoventilation, you know that means you're not really breathing that well. And if you're not really breathing that well, then you probably could look at this list and figure out what else is related to that. Now, again, when you're not breathing that well, like shallow breathing or something crazy, you are not getting rid of, you guessed it, CO2. So carbon dioxide, if you can understand that it's an acid, and if you're not breathing really well, you're not getting rid of the acid, then of course you're in acidosis. That just makes perfect sense. So in any condition where you're not breathing really well, you can assume this patient's going to become acidotic. Now, the breathing issue must be longer than a few minutes, like if you're scared to death and you hyperventilate, that's not going to do it. Or if you're at the very beginning stages of asthma and you're hyperventilating, no, it's hypoventilation. You're not breathing well at all. So if you look up here, I'm going to put just a little star by all of the conditions that pretty much are hypoventilation issues. Hypoventilation issues is, of course, COPD and emphysema. Common sense. This is a respiratory condition. You're not really breathing that well. You're going to retain CO2. CO2 is an acid. Now your pH is low. Okay, so let's do some more. I think you would agree, pulmonary edema. I had a patient with this the other day. They weren't breathing very well. They were not getting rid of their CO2. They were shallow breathing. Their lungs are filled with fluid. Common sense, okay? So let's do another one. Pneumonia. If you have pneumonia, clearly your lungs are definitely filled with infected fluid. Sometimes we even say a precursor to pneumonia is atelectasis. Certainly I could throw COVID up here because it's a COVID pneumonia. It's a type of pneumonia. We have so many types of pneumonias. We have ventilator-acquired pneumonia. We have hospital-acquired pneumonia. We have community-acquired pneumonia. And then we have COVID pneumonia. And then we also have post-op pneumonia. So right next to pneumonia, right up underneath that is post-op patient. This patient is the one that you keep saying over and over again, I need you to take some deep breaths. Come on, your surgery's over. Give me some deep breaths. And if you look at the pulse ox while you're telling the patient to come on, give me some deep breaths, it shoots straight up. And you will see clearly, oh, wow. As soon as they got rid of the acid or the CO2, the oxygen filled in the space because they took that deep breath in. And as you know, when you breathe in oxygen. When you breathe out CO2 or carbon dioxide. So you just got to kind of keep thinking that way, right? So there you go. So you have pretty much everything that I put a little star by. You have your COPD, emphysema, pulmonary edema, hypoventilation, pneumonia, post-op. Those are all like respiratorily related conditions. So I'm sure you get the fact that this would be sort of like a respiratory acidosis. Not really a long stretch to go there. So that's the deal. Now, there are other reasons for why a patient goes into acidosis that have absolutely nothing to do with breathing. That second concept, which you're going to see me circle up here, is the issue of poisons and toxins. Anything in the body that is toxic or poisonous would also give you an acidotic state. We can break it on down to just literally factual information of a 3-year-old taking some toxic agent in their body, antifreeze, bleach, anything poisonous that they might ingest would probably cause a severe acidotic state if we don't get it out of their body. So any poison or toxin, okay? Overdoses of medications might cause acidosis for lots of different reasons, but let's just look at aspirin. This is the legal abbreviation for aspirin, ASA. ASA is actually acetylsalicylic acid. Acetylsalicylic acid. So acetylsalicylic acid in the body is going to cause, of course, acidosis. This is not hard. You can kind of put the 2 and 2 together and go, oh yeah, that makes sense. All right, so acetylsalicylic acid if you took too many aspirin, which, by the way, when I was little, that was kind of common because they had this thing called baby aspirin, and it was orange, and it was tasty, and kids used to just kind of eat it like it's candy if you didn't lock it up. And that's what we saw a lot of back in the day. We don't see as much now, but that is indeed what we would see. So let's look at some other examples of toxins and poisons. Of course, a patient having sepsis would be pretty toxic, right? Because in this case, the poison is actually some type of bacteria or virus. It is taking over their body. It is invading their bloodstream. Now their body has a poisonous illness from bacteria or fungus or virus that is causing them to become septic. Certainly we know we see this with COVID, right? So we know that. Kidney failure. Well, common sense tells us that part of the function of the kidneys is to excrete the poisons and toxins that are in the blood. In fact, what I tell patients, especially the dialysis patients, is I try to explain to patients, you get dialysis every Monday, Wednesday, and Friday, or every Tuesday, Thursday, and Saturday to clear the poison out of your blood. Now, in essence, I tell them when you don't go to dialysis, the poison is still in your blood. And what does that mean? That means when you have dialysis, we take urine out of your blood. When you don't go to dialysis, urine is still in your blood. And that kind of puts it in perspective for the patient that this is a very necessary procedure. If you miss in the day, don't make sense at all. Very deadly. I actually lost a cousin who missed his dialysis. He's dead now, my age, even younger. So it's kind of crazy how people don't take it serious, you know, their dialysis appointments. Okay, so kidney failure then would definitely put poisons and toxins in the body. Creatinine and blood urea nitrogen and uric acid. Uh-oh, there we go. Stop there, park there, take a little break, put some stripper glitter on the handout. Uric acid, kidney failure, uric acid. Acid, there's that word again, acidosis, okay? So that's another good one to know. Now the next one, diabetes, not so much, but the complication of diabetes, which is DKA, is another example of what a patient would become acidotic, and it really wouldn't have anything to do with respiratory issues. So we know that your first job whenever you're taking a test is to not just say DKA. Literally, while you're taking the test, say the actual word so that it clues you in. Because if you say the actual words, it's diabetic, keto, acidosis. I mean, you can't get that wrong on a test. It's telling you acidosis. Like, you know, come on, you've got to get this. All right, so we have DKA, kidney failure, sepsis, poisons, and toxins. Well, there's a tricky one thrown in here for good measure. Real tricky. Here it is. Shock. One of the things that I tell you to remember for the rest of your life is that all shock patients have a low BP or blood pressure. If you consider that no matter what shock it is, all of it has a low blood pressure, whether it's septic shock, hypovolemic shock, distributive shock, cardiogenic shock, anaphylactic shock, doesn't really matter, neurogenic shock, it doesn't matter. All shock, every single one of them, has a low BP or blood pressure. Now, what I tell you to remember about that is that BP, the letters BP, stand for blood perfusing kidneys. So if you don't have any blood perfusing your kidneys, then your kidneys will fail, and here we are again with retaining uric acid and retaining horrible electrolytes like potassium. So all shock has low blood pressure. We affectionately say no BP, no PP, because if you have kidney failure, you can't make urine. And one of the signs that you are in shock is that you're not really making a lot of urine. So all of that is to say that shock is an example of kidney failure ultimately, because you need an adequate blood pressure to perfuse the kidneys, for the kidneys to make urine and get rid of toxic waste. Okay, so that should kind of literally make perfect sense to you. All right, now we still have one more, and actually we do have jokes. I mean, you know how it is. students use all kinds of tricks to get the test right. In this situation, we have one lonely little word up here, the only word left because we've covered every single one of these words, and that is diarrhea. So it's like, okay, what's the trick? Well, the trick is if it comes out of your ass, it's acidosis. And of course, it's not going to get you any money, but it will get you a point on the test. My job is to make you understand it. Why? Why is that true? Well, for that purpose, you really have to go back to the bodily fluids that I started this lecture with. If you look down here, you will see the large intestine is acidic. But then if you cross the street over into alkaline, the small intestine is actually alkalinic. Diarrhea comes from the small intestine where all the alkaline fluid sits. So if you have diarrhea, which means things are going to run right through you super duper fast without you absorbing one nutrient. And so if you have diarrhea, then you essentially have lost all of your alkalinic fluid. And when you lose all the alkaline fluid, acid takes over. Okay, so that is the rationale for why that happens. Now, again, on this side of the board is all acidosis. The polar opposite, of course, is alkalosis. I'm going to pull up the packet and show you some handouts in here that you should be well aware of. If you turn to the first one I want to go over with you, because it is acidosis that we cover first, you need to find this handout where it says causes of acidosis. And pretty much everything that is on this column is on this list. You can see the hypoventilation. You can see the pulmonary edema. There is something I want you to kind of clarify on your sheet there. Under the top part where you see this bag over the head and it says airway obstruction, make sure you just put COPD, because what is COPD? Chronic obstructive pulmonary disease. It's an obstructive pulmonary disease, so you need to put that up there. And then you'll see another area right underneath that where it says neuromuscular disease. This is your multiple sclerosis, your myasthenia gravis, your Guillain-Barré, your patients with these autoimmune neuromuscular diseases, stroke patients, cerebral palsy, anything where the neural and the muscles don't work. Okay, so that is it. You got it. Acidosis. Now, we're going to cover alkalosis in a minute.